Okay, welcome back again. This time we're going to be talking about a slightly different topic versus what we did last time. Last time we were talking about ketones, which is not a very complicated topic. The most important thing is concerning the emergency situations with that one. With this topic, it's a bit more dynamic, so it contains a lot more information. I'm going to try to break it down. Please check with the PowerPoint slide that comes with this lecture regarding what is extremely important involved in this topic. Now, the echinocenoids refers to a group of fatty acid compounds that are actually derived from arachidonic acid. So this whole pathway and all the different byproducts we're going to be talking about are going to be, another term that's going to be used for them is the arachidonic acid derivatives. This pathway is very much concerned with an enzyme called COX, cyclooxygenase. Now, there are two types. There is cyclooxygenase 1 and there's cyclooxygenase 2. We're going to talk about them as we go on. Now, where is a good chunk of your arachidonic acid? A good amount of your arachidonic acid is going to be found especially in cell membranes. Now, it's also going to be found, depending on what cell type you're looking at, being produced in different ways. You do not need to necessarily remember this pathway. What you should remember, though, are the major metabolites. So let us quickly start off. So we have our plasma membrane. Please remember also involving this reaction, where are we getting our arachidonic acid? Remember, we get our plasma membrane derivatives are coming extensively from our essential fatty acids, linolenic and linoleic acid. And remember where those come from. Those are going to be plant-based. Please don't forget them. Our essential fatty acids are going to be responsible for this. So what we have is our plasma membrane. We have our phospholipase A2. Is going to respond for breaking down plasma membrane to give us arachidonic acid. From arachidonic acid, we are going to have another group of enzymes, which are going to be our cyclooxygenase. We have cyclooxygenase 1 and 2. Your PowerPoint goes into a bit more detail on this, so please review your PowerPoint. With the cyclooxygenase, we are now going to be responsible for producing, let me write another way, our phospholipids. No, sorry, not phospholipids. We're responsible for making our prostaglandins, prostaglandins, our thromboxane A2, as well as our prostacyclins. We also have another enzyme that's going to be working on this, which is, of course, going to be our lipooxygenase. GenAs, which is, of course, going to be responsible for making our glucogenes. Now, regarding these different products, the most important from this list that you probably should know very well is, of course, our prostaglandins. Those are very important. Another one that is also good to know is our thromboxane A2. Our prostacyclins work very similar to our prostaglandins. Within our prostaglandins, there are several different subgroups. Those different subgroups you mostly don't need to know. Mostly. There are exceptions to this. One of the major prostaglandins you should know is prostaglandin E2. What makes this prostaglandin so important? Well, prostaglandin E2 is important as a major vasodilator, especially the renal arteries. Especially the arteries responsible for supplying blood to the kidneys depend on prostaglandin E2. So it's a major vasodilator. Major, especially for the kidneys. What else is also a major factor? Prostaglandins are also a major factor in the maintenance of the mucoid or mucus layer of the stomach. So, maintain mucus, gastric mucosal layer. That's one. What else? It's also very good in inflammation, as well as pain perception. What else? The prostaglandins are also very good in especially uterine contractions. So that's another factor which they can actually be involved in. So yes, this prostaglandins are involved in quite a number. Oh, sorry, this one, uterine contraction, is prostaglandin GF2, prostaglandin GF2. That's the one that's usually involved, especially in uterine contraction. The others are mostly related to prostaglandin 2. Thromboxane A2 is a potent vasoconstrictor. That's one of the functions of it, but it is not the function that you are expected to know, especially for your boards. This is good to know for you. But the one they're mostly going to test you on is that thromboxane A2 is a very potent platelet aggregator. So in other words, it helps in the formation of clots. That is something your boards expect you to know very well. Platelet aggregation or clot maintenance, those are the kind of things that thromboxane A2 is very important for. The prostacyclins are not that high yields for you to know. Many of their functions are very similar to the prostaglandins, so I'm not going to spend much time on them. In your first aid book, there's something mentioned about them. It is also mentioned a few other things in the PowerPoint. But generally, the ones I need you guys to know the most about is thromboxane A2 and the prostaglandins, especially prostaglandin E2. Leukotrienes are very important in activation of the immune system. So the immune system is very much dependent on leukotriene activity. We are not going to spend much time on this. This will be hopefully when you guys reach farm, whoever is teaching farm at the time when you guys reach there, they will spend a bit more time on this topic. But for biochemistry, what you guys need to know the most about is your prostaglandins and your thromboxanes. Now, since these are derived from our arachidonic acid involving our cyclooxygenase, can you guys think of any pharmacological reason why this pathway might be important? Well, first off, big one, vasodilator, inflammation, pain. Do we have drugs that treat any of these things? Yes. We have, for instance, we give people steroids whenever they have inflammation, especially chronic inflammation. How do steroids work? They block this step. So steroids, that's if you guys remember, one of the ways we treat inflammation, we give them steroids. And steroids, especially corticosteroids, they block the activity of phospholipase A2. We give drugs that, especially a very famous drug, that actually affects pain. One of the most commonly associated drugs in prevention of pain is, of course, NSAIDs, which is, of course, our non-steroidal anti-inflammatory drugs. Who is the most important in the NSAIDs group? Aspirin. Aspirin is a very, very famous drug. It's one of the most commonly used drugs on the planet. And its main mechanism, of course, is that it affects cyclooxygenase. Aspirin is known as a non-selective NSAID because it blocks both COX-1 and COX-2. What are the other types of NSAIDs you should know? Indomethacin. That's another one you should know. There's also Ketorolac. There's a whole bunch of them. But for this class, you're not going to be expected to know most of them. The ones you should know are aspirin and indomethacin. Now, What are the special high yield situations where remembering this pathway is important? First off, if I give someone aspirin or another NSAID, and since they block cyclooxygenases, that means they're blocking a major vasodilator for the kidneys. Now, what usually happens when you give someone a drug that's going to interfere with the kidney's blood supply? How does the kidney react when you interfere with its blood supply? Well, first off, kidney doesn't like that. It is, of course, going to activate the RAS system. What is the RAS system going to do? It's going to raise blood pressure. If your patient already has hypertension, do you want to raise their blood pressure? No, you do not. So you have to be very careful when giving someone aspirin who has a history of hypertensive disease or cardiovascular disease generally. You have to be very careful. What else? We said that prostaglandins also help maintain the mucosal layer of the stomach. Someone who has an ulcer, would you want to give them a drug that interferes with their body's ability to maintain their mucosal lining? No, you wouldn't, because that is going to make the ulcer worse. So usually we have to be very careful when giving persons aspirin. This is one of the reasons why you also don't want to give somebody aspirin chronically and long term. So if you're taking aspirin every single day for whatever chronic disease you may have, one of the things your doctor must worry about is the possibility of ulcer formation if you don't already have an ulcer. What else do we worry about? Inflammation. Now, this is actually a good thing. By giving a drug that interferes with inflammation is actually potentially a very good thing. Pain. Giving a drug that interferes with pain perception is great. Now, these different functions of aspirin are the reason why it is known as an anti-inflammatory. It is known as an antipyretic, fever, because one of the things with fever is also going to relate to inflammation as well. So I didn't put that on this list, but aspirin is also used as an antipyretic because that's pretty much anti-fever. Fever medication. That is good for aspirin. It is also known as an analgesic. That means it's good for pain perception. These are some of the uses. It is also known to block the formation of blood clots. That's one of the reasons why we use it as a blood thinner or anticoagulant, because it interferes with thromboxane A2. So these are some of the great and wonderful things of aspirin. Now we have to quickly talk about situations where we would give prostaglandin inhibitor like COX or a thromboxane inhibitor like NSAIDs. Now, how do we do this and what are the situations where we're going to use it? First off, I am going to ask you guys a little bit about Embry. I know Embry was so long ago, but do you remember the development of the heart? Do you guys remember the different stages and the different things that are usually involved in the heart? Do you remember something called a ductus arteriosus? Well, what is the ductus arteriosus? A quick reminder. We know we have, this is my heart, okay? This is my version of the heart. It's a nice little box. We know we have the left atria, we have the right atria. We know we have the left ventricle, and we know we have the right ventricle. We know coming off from the left ventricle and from the right ventricle are very important blood vessels. So let us do a quick reminder of how blood comes into the heart. We know blood is going to come in on the right side, and that's, of course, going to be our vena cava, superior and inferior vena cava. We know it's going to go into the right atrium. We know it's going to pass from the right atrium to the right ventricle. From the right atrium to the right ventricle, it's going to pass through the valve. Now, once it passes our valve, it's then going to go into this very important blood vessel, which is going to be our pulmonary artery. This is, of course, all deoxygenated blood. This deoxygenated blood is then going to move on to the lungs. So I'm going to put lung here. That's not okay. Lungs here. From the lungs, we are then going to have blood flow from lungs, then go into our left atrium, and that's, of course, going to be our pulmonary vein. Then from our left atrium, we're going to go to our left ventricle. From our left ventricle, we're then going to go into our aorta. So, put aorta here. And then from here, it's going to go to the body. That is normal. Now, let us say we have a situation where the lungs are not able to receive blood. And that occurs naturally in every child. Usually, if you remember, the lungs do not open up until the baby is born and the baby takes his first breath. So where does blood flow reach the body? How does it get there? That, if you remember, usually coming from the placenta, we're going to, of course, have the umbilical arteries, which is, of course, going to supply blood from the mother, and it's going to go into the vena cava. From the vena cava, it's going to carry the normal blood flow. However, it does not go to the lungs because the lungs are closed. Instead, if you guys remember, it moves from the pulmonary artery to the aorta through what is known as a ductus arteriosus. You guys remember that. That ductus arteriosus is going to be a mechanism to allow blood to go from the right side to the left side and from the aorta and then into the body. That is what the ductus arteriosus. It usually closes by the time we take our first breath and the lungs open up. Now, what is responsible for opening and maintaining the ductus arteriosus? It is, of course, our intimal lining, which is usually found within the blood vessel itself, which is, of course, our endothelial cells. Those endothelial cells are going to be making prostaglandins, and they usually stop making prostaglandins at the time of our first breath, and as a result, the blood vessel closes. So what happens in a situation where we have our ductus arteriosus being maintained? We call it a PDA, a patent ductus arteriosus, and that allows blood flow to go from the pulmonary artery towards the aorta. Now, these, of course, are situations that we are going to be very cognizant of in heart development. Is there a time when, as a doctor, you'd want to maintain the ductus arteriosus? Yes. There are situations when you want to maintain it, but there are also situations when you want to close it. How do we close it? You already know. Since this is maintained by prostaglandins, we give the patient an NSAID, like indomethacin. Indomethacin, give it to the child, will cause a decrease in prostaglandin production, and that will close the ductus arteriosus. But let us say we have a child that is born with a situation where we have inability to pump blood from the right ventricle to the lungs. For instance, pulmonary hypertension. Pulmonary hypertension, there's increased pressure inside the pulmonary artery, and we can't push blood from the right ventricle to the lungs. In a situation like that, maintaining a ductus arteriosus is a good thing because it allows blood to be able to still circulate in the body. However, if blood doesn't get to the lungs, it can't be oxygenated. So that again creates a problem. So that, of course, is going to cause cyanosis. So let us say we have another situation. Let us say we have a situation where we have what is called total transposition of the great vessels. That is a situation, maybe you guys did that in Embry, not entirely sure, but you should have done it. What does that disease condition look like? Total anomalous blood flow is a situation like this. I'm using my box heart again. So we have still our right atrium, our right ventricle, our left atrium, our left ventricle, and we have our vessels coming off. However, this is where a problem arises. In total great transposition of the great vessels, off the right ventricle is not the pulmonary artery. What we have coming off the right ventricle is the aorta. What we have coming off the left ventricle is the pulmonary artery. So, if we have this situation, the right atrium is still probably going to have the vena cava, the left atrium is still probably going to have the pulmonary vein, and that's coming from the lungs. So, where is the pulmonary artery going? It's still going to the lungs. The lungs is still sending blood to the pulmonary vein. But here's the problem. This is a closed loop. There's nothing here going to the body. This is also a closed loop. This is called transposition of the great vessels. It is, of course, a cardiac surgery problem, and it does occur. It is also diseases like titular fallout. We also worry about that one as well. In a disease situation like this, we have to find a way to connect two completely closed circuits. When we have that, how do we create that link? We maintain the ductus arteriosus. So we give the mother corticosteroids, or we can give them prostaglandins. Well, most likely, not corticosteroids, ignore that part. We give the mother prostaglandins, or prostaglandin E2 specifically. Prostaglandin E2 maintains this ductus arteriosus, and we have what is known as a medically induced PDA. And this allows blood to go from the right side to the left side. Another thing which also happens in this disease is that you may also have a VSD, which is of course our ventricular septal defect. That may also be present in this patient. That's another way how blood can go from the right side to the left side or left side to the right side. Those are things that occur in this disease as well. And this is one of the reasons why we give the patient prostaglandin to maintain the ductus arteriosus, so that there's a connection between the body and the lungs. This, of course, has to be corrected surgically. Same thing with this as well, where we had pulmonary hypertension. This also needs to be corrected surgically. This, of course, will be done by your pediatric heart surgeon. So until this is corrected, we maintain the ductus arteriosus by giving the patient a prostaglandin. Once it is corrected, we then close the ductus arteriosus by giving the patient indomethacin, which is, of course, a COX inhibitor. Now, your textbook does go into the fact that there is more than one type of COX inhibitor. We have what are called the non-selectives that block both COX-1 and COX-2. We also have the selectives, like, for instance, Celebrex or Rifaxiba or Celecoxib. Those are also what is known as selective COX inhibitors. Selective COX inhibitors are done in situations where we do not want to affect prostaglandin E2 and we don't want to affect the stomach. So instead, it's going to affect our other sources of our COX metabolites. The book goes in a little bit more detail into it. You guys can check it out. It's also mentioned in the slides, and it's also mentioned in your first aid textbook. So you can go into that. For biochemistry, we are not going to be testing you guys on the different types of COX inhibitors. We're not going to test any of the different COX pathways. Pharmacology will test you on it though. So again, for this class, all I need you guys to know, the major metabolites of the arachidonic acid pathway, the major ones, prostaglandins and thromboxane. Those are the major factors I want you to know. I want you to know, how do we interfere with this pathway? The NSAIDs, which are, of course, are cycloogenase, oxygenase inhibitors. When are situations where knowing that prostaglandins can open up blood vessels be a good thing? We gave you an example, pulmonary hypertension. We also gave you another example, which is transposition of the great vessels. This is when opening up of the PDA is a good thing. Once this is corrected, we can close it by giving the patient NSAIDs. And that NSAID that is usually tested is indomethacin. Those are the most important things with echinocyoids I want you guys to know. And please remember all the functions that the individual